Hey y'all, it's me, Dr. Smina Ramon, Gyno Girl, here for another exciting episode of Gyno Girl TV. I was been a little bit away and I want to just do some recaps on some of the things I've learned between going to the Menopause conference as well as the World Meeting on Sexual Medicine. And so we're going to talk a little bit about some new and potentially exciting things to come in women's health, especially in menopause care. So let's get at it. Hey y'all, it's me, Dr. Smina Ramon, Gyno Girl. Okay, I'm back. I was away because I was conferencing, and you guys know how much I love a good conference because I think that we get a lot of good information, what's the latest and greatest. And so I want to talk to you a little bit about that. But I'm Dr. Smina Ramon. I'm a board certified gynecologist. I work in downtown Chicago with my own private practice. I'm licensed in Illinois, Indiana, California, Arizona, and Wisconsin. I specialize in sexual medicine and menopause management and vulvar skin diseases as well. So I also have a podcast, Gyno Girl Presents Sex, Drugs, and Hormones, where I interview a lot of cool people and talk to a lot of different individuals in this arena. But today I want to talk about my recent adventures. We actually had the Menopause Society conference here in Chicago in September, and I also recently attended the World Meeting on Sexual Medicine in Rio. And so I have a lot to say about some of the things that we learned and experienced, and so I want to talk about it. So first of all, the Menopause conference was awesome. I love going to conferences because new data is presented, but also you get to see some of your friends and colleagues from across the country. You'll see that on Instagram and here that I've talked about some of the, people that are sometimes referred to as the menopause crew or the menopause, that we kind of get together and talk about, all things perimenopause and menopause. There was a lot of emphasis. And so, it's good to get together with other people and, review how we treat patients and our treatment strategies on certain things. But also it's fun because, we all have similar passions and interests. But, with the Menopause conference this year, there was a lot of discussion around artificial intelligence and how it might play a role in some of management and treatment in terms of this big black hole of people that don't get access to appropriate care when it comes to the perimenopause and menopause. And I think that's very important to remember because by 2030, there will be 1.1 billion women in menopause. And that's a lot of patients that, maybe aren't getting the help they need and maybe need to get more help. So I think it's important to keep that in mind. And so there was some discussion around, how we can use artificial intelligence and virtual reality to kind of do cognitive behavioral therapy for some of the issues around, depression, anxiety, and some, mental wellness concerns and for those patients that don't have access. Obviously, this is not about sort of replacing any medical treatments that we have, but maybe augmenting or filling a void when it comes to menopause care. And I think that's why, you'll see so many platforms that are now available for women in the midlife. A lot of these platforms are great, like MIDI Health and Alloy Health, and there are some listed. These are virtual platforms where you could see what the Heather Hirsch Collaborative, virtual platforms where you can see a menopause provider of some type to help you navigate your journey. I obviously do some virtual visits as well, but what I find to be sort of the missing piece is not having, clinicians that you can access that will actually put their eyes on you and see you. Because I see a lot of issues when it comes to external vulvar skin disease. I've done so many discussions about vulvodynia or lichen sclerosis or some of these inflammatory skin diseases of the vulva. It's important to remember, you have to look down there, but someone else does too. So I think if that's not happening, then that can be somewhat problematic for some patients when it comes to getting a correct diagnosis and correct treatment. And so a lot of it is, very beneficial to be able to do virtually or to use, AI-generated technology to fill a gap until you can get to someone that can actually see you. So I think that's very Some of the discussion was sort of around menopause and early menopause and the consequences when it comes to ovarian aging, right? So if the average age of menopause is around 51 and a half in North America, there are patients that go through menopause early, and if it's primary ovarian insufficiency, that's less than age 40. I've done a video about that. But what we see is that there are profound medical impact of going through menopause too early, benefit to entering menopause later. And so I think that was some of the discussions around this kind of idea of either extending the menopausal transition to give you time for more of your estrogen. Remember, estrogen, progesterone, testosterone are markedly reduced after your ovaries retire. And so it's really important to remember that for patients that go through menopause early, and I'm just thinking, less than age 40, we do see significant increases in obesity, heart disease, diabetes, and remember, heart disease is still the number one killer in women, and as well as issues around, cognitive stress, dementia, Alzheimer's. Some of these issues do come up. And so when patients enter menopause late, and that's kind of like later than 55, that we do see, improvement in overall or benefit when it comes to cardiovascular health, brain health, and overall longevity. So, there was a couple of lectures that were given on, can we extend the time that you have this menopausal transition? Is it possible to give you more ovarian function? There was discussions around ovarian transplant and how it's been used in technology-wise, where they transplant a piece of the ovary and put it either under your arm or in your abdomen, and you get about 2 years worth of additional hormones and, the benefit of that when it comes to, fertility or versus, your overall cardiovascular, mental, brain health, all the things that we know early menopause puts you at risk for. So there was, discussions around that. What does it mean, if you're born with 1 million eggs when you are coming out of the womb, and it kind of like depletes over time and you're born with a limited amount of eggs, right? What happens over time? Is there a way to sort of prevent the loss of these follicles, or a way to improve the quality? Or is there a way to talk about reducing the oxidative stress around the eggs to preserve it? So there are all these potential new basic science technologies that are trying to be looked at. We just don't have any of that available at this juncture, right? But these are things that were talked about in the future. This might be something we are able to offer women either going through early menopause or not. Some of the things that can put you into early menopause, like a history of endometriosis, smoking, genetics, chemical exposures, so these are all things that we have to think about when it comes to our lifestyle changes and lifestyle modifications. And I think that there were a couple of really interesting discussions. We had a really cool clinician, this surgeon that came to talk to us about voice as a predictor for health. Her name was Dr. Yael Ben-Susan. She gave an amazing talk. And this was kind of one of the most interesting things that I really took from this was that there are changes in the fundamental frequency of your voice when it comes to menopausal transition. And estrogen and progesterone receptors are in your larynx. And so we get an increase in vocal cord mass when you lose these hormones, right? And so sometimes it affects your voice range. And also it's kind of a lower pitch, more hoarseness. And fundamentally, the pitch can change because of muscle atrophy, loss of collagen. And that's just from aging. That's for men and women. So you have a loss of collagen and muscle atrophy that can lead to changes in the pitch of your voice. But then estrogen, in addition, the loss of estrogen causes more dryness. And what's also interesting is that patients who have really super physiologic levels of testosterone, where they're giving, I think I've talked about, the use of testosterone pellets and the dangers of using testosterone pellets when it comes to some of the hormone therapies that are offered, because it puts you into super physiologic levels. So with that high levels of testosterone, your pitch can become lower and increase roughness. And so there are women that have come to this ENT doctor in distress because of the way they sound and how they're mistaken for men, or the fact that their voice just continues to change. So voice as an indicator and predictor of health was really pretty interesting. There was some discussion around virtual reality as a form of cognitive behavioral therapy. in menopause management when it comes to vasomotor symptoms, when it comes to depressive and anxiety symptoms. And really important, there is a lot of talk around sex and menopause, and how sexual pain still remains one of the biggest challenges when it comes to menopause and perimenopause. And we've talked about this ad nauseum, the genital urinary syndrome menopause, the use of local estrogen therapy, which would be in the vagina or the vulva, and sometimes testosterone in the vulva as well. And that helps to reduce the amount of sexual pain you may experience. So there was more of a discussion around that as well. What was referred to as just local estrogen therapy. There was discussion around that, and also treating that before treating desire, which, we always do anyway. But when patients have hypoactive sexual desire disorder, which again, I've done videos on, how we need to be cognizant of treating that pain before treating the desire problems, because no one usually has desire to have sex if they're in pain, right? So I think that was... There was a really good discussion around the musculoskeletal syndrome menopause, right? So there was a discussion around how the primary indications for hormone therapy. Let's just talk for a second about that. Primary indications for hormone therapy based on our best evidence. What do the guidelines say? And the guidelines still state that treatment of vasomotor symptoms, which we think vasomotor symptoms has everything to do with something happening on cellular level. So if you're experiencing them, you might be more inclined to get insulin resistance, you might be more inclined to have sleep disturbance, more inclined to have cardiovascular disease. So some of these things, and even with dementia, like there's no role for using menopausal hormonal therapy to prevent dementia as of yet. But patients who have vasomotor symptoms, if you're treating that, you can improve their cognitive function and possibly help their brain function as well in the long term. So I think that was an important distinctive point that was made. The same can be said for cardiovascular disease. We do not give menopausal hormonal therapy for primary prevention of cardiovascular disease, meaning we don't give it because we think it's going to help reduce your risk of, dying from a heart attack, or, even though we can see people's lipid profiles improve and all of these things, it's not primary prevention, but it might be a secondary benefit for a lot of patients. But if you're treating someone who has vasomotor symptoms, you're going to actually improve their risk of cardiovascular disease. So it's kind of one of these things, if a patient doesn't have vasomotor symptoms, maybe that means that they don't have something on a cellular level that's going to make them more at risk for so they might not benefit in terms of cardiovascular health. And so reviewing the primary indications for menopausal hormonal therapy was pretty big. So looking at vasomotor symptoms is one, looking at the genital urinary syndrome menopause, which was talked about ad nauseum, sexual pain, vaginal dryness, urinary frequency, urgency, recurrent UTIs, that kind of thing. Those are all very critical and important for the treatment of genital urinary syndrome menopause, treating that with local estrogen therapy or a local DHEA therapy. So that was re-emphasized. And then the prevention of osteoporosis. So 1 in 2 women will experience osteoporosis in their lifetime. If a woman falls, especially like a hip fracture, something upwards of a 30% chance in losing your life within that year of recovery. So it's not a benign thing. It's silent until it's not, right? Osteoporosis is not anything that you feel on a day-to-day basis, but you will if the bones are frail enough. And so menopausal hormonal therapy is one of the best things, which is estrogen, right? Estrogen is one of the best things for your bones. So we talked about the syndrome of musculoskeletal syndrome of menopause, which is really like what my friend Dr. Vonda Wright, she published this musculoskeletal syndrome of menopause, which includes the body aches, the muscle aches, the arthritis, the joint pain, the frozen shoulder, the kind of things that, you just feel like your body's breaking. It's breaking down, the loss of muscle mass, sarcopenia, the loss of bone density, and you feel like you're just falling apart. That this is an actual syndrome related to hormone deficiency, and even the delta, the highs of perimenopause where you get too much estrogen, and the lows of perimenopause where you're like really deficient. And this roller coaster of perimenopause where some months you might feel like you have a lot of estrogen, right? And you're bleeding more and you have headaches and breast tenderness. Those are months where you have a lot of estrogen, and so you're experiencing symptoms from too much estrogen. And then the very lows of perimenopause where you're having hot flashes, vaginal dryness, these other symptoms related to lack of estrogen, right? And so this delta, high to low, in perimenopause is the real issue when it comes to a lot of the symptoms and the roller coaster that is perimenopause. September was the first ever perimenopause awareness month. There was a lot of talk around perimenopause and how it is a time of chaos because of the highs and lows with their hormones. So what happens is, you're losing your eggs and you're not making any new eggs, right? That's not something that happens for women. What happens some months is that your brain sends your ovaries a signal like, hey, it's time to ovulate. Let's recruit some of these follicles. So you recruit maybe more than one follicle at a time to try to, and you almost like super ovulate as if your ovaries were being super stimulated. We call these loop cycles. And that's when your estrogen levels can be really high. People experience breast tenderness, headaches, significant vaginal bleeding, especially if there's no structural problems like fibroids, polyps, that kind of thing, right? And so that happens some months for women in perimenopause, and perimenopause is around the time of menopause, which means around the time leading up to that final menstrual period, the 12 months that happen. This whole perimenopausal transition can be months. It can last up to a decade for some patients. So it can be quite miserable. There was a lot of talk around this delta of estrogen, highs to lows. That is the causative agent for all the distress that women feel. Whether or not it's cognitive distress, oh my God, I forgot what I was going to say, brain fog, whether or not it's mental health issues where you're crying a lot. Rage, the rage of perimenopause is real. Feeling of like just being angry all the time, the feeling of crying all the time, all of these things. And so all of that was discussed in this and how the best ways to treat it. And sometimes it's menopausal hormone therapy. Sometimes it's, hey, I got to add a little serotonin to the mix. I got to get an SSRI, these antidepressants or anti-anxiety medications, because anxiety is one of the other big things that happens. And so you have all these things that are happening at once. And this discussion really centered around some of these symptoms. There was some talk around perimenopausal bleeding and how you can have really heavy flow some months, and you want to make sure what's happening in the uterus. If there's something structurally happening, is there an endometrial polyp, which is kind of like, I like to call it like the skin tag of the endometrium, where you have too much tissue here, and then all of a sudden you develop a polyp. That is the cause of heavy bleeding or erratic bleeding. The same with fibroids. Fibroids are these masses in the muscle of the uterus. They can be under the skin of the uterus. They can be deep in the muscle of the uterus, and they can kind of abut the endometrium. And that's like submucous fibroid or intramural or subserosal and reversal. So some of these things were discussed and how to treat them. Sometimes it's treatment with the intrauterine device like a Mirena. I'll do a separate video on that altogether because that's something I treat all the time in my office. Sometimes it's looking at removal of some of these fibroids. Sometimes it's putting you on menopausal hormonal therapy and progesterone to suppress it. So there's a lot that can be done. But a lot of this discussion was happening, and we talked about all of this. One of the other things that was really interesting at the menopause conference in Chicago was the idea of, are we over-medicalizing menopause? And so the fact of the matter is the number of menopausal hormone therapy prescriptions is actually going down. We are down to 1.8% of women that receive menopausal hormonal therapy for their menopausal symptoms. And so it's actually going down. So we're not over-medicalizing it. Women often are not getting the correct information on social media. They're not actually maybe getting different things that are pushed in their direction. So, and I talked about this in the Menopause Gold Rush video. And I think that it's really important to remember that things that are happening to your body as you're losing estrogen, as you're losing progesterone, and as you're reducing the amount of testosterone that you make are really important. And so it affects your whole system because we have estrogen receptors from head to toe. I've said this many times. And so it can affect your brain. It can affect your bones. It can affect your muscles. It can affect your genitourinary symptoms. It can affect everything. And people get weird vertigo. They might have because you have estrogen receptors in your inner ear. Like I said, it can affect your voice. There's a lot in perimenopause and menopause that can be helped with menopausal hormonal therapy, but it's only one part of the toolkit that we use. We have to remember lifestyle modifications. People talk about, is it going to help me lose weight? Is it going to help my age? Is it going to help this and that? One of the biggest things I talk about with my patients is stress reduction. You got to try to get a hold of the chaos in your life and reduce it. And this is something I struggle with myself, and I haven't gotten there yet, but it is one of the things that we have to get better at. we got to get better with our sleep pattern, right? And there was a lot of discussion around insomnia in perimenopause and menopause. Insomnia, really 3 months where you're not sleeping, where you're not falling asleep, or where you keep getting up. And it affects the quality of your life, and it affects your ability to concentrate the next day. So, and actually there's really good data to suggest that cognitive behavioral therapy with a therapist is very important and can help sleep almost better than any medication. So that's something to keep in mind. We got to keep in mind our sleep hygiene. We got to keep in mind trying to reduce stress, reduce the chaos, and that will overall help this transition as well. What are you putting in your body, right? Are you getting a Mediterranean diet? It's kind of like the ideal diet that people talk about, where you're getting a lot of protein, you're getting increased fiber, and you're reducing, the carbohydrates. I'm not big on elimination diets, so I don't think that that's the way to go. But I think that, following these diets that are high in antioxidants that will reduce the amount of inflammation are really important. And the fourth thing is really around, exercise, right? Cardiovascular, 150 minutes a week of exercise you got to try to get in. And that should include muscle. That should include building your muscles. That should include weightlifting and lifting and plyometrics and trying to do things to improve overall muscle tone as well as, longevity and obesity, right? These are things that are very important. And then menopausal hormone therapy is very beneficial for a lot of patients, so we have to consider that in our toolkit. But these are all the things, right? There's multiple things in the toolkit. And so there's no magic bullet, guys. Newsflash. There's no panacea when it comes to perimenopause and menopause. There's no magic bullet. But you know what? It is a time that you can conquer, and it is a time that you can educate yourself about your body and understand what's going on. And it is a time for you to really try to be the best version of yourself, to improve that quality of life, to reduce frailty. We got to reduce that frailty, right? This is all about preventing you from getting into that nursing home and falling and not knowing where you are. All the things, right? So all of this to say that there's a lot of things available. There's things that might be coming on the pipeline. There's no magic panacea when it comes to getting through this transition. And some people breeze right through it. And more power to you. I have patients that come to me like, I'm actually doing okay, so do I need hormone therapy? And unless you're concerned about your bone health and, are risking your risk of osteoporosis are there, no, you don't need hormone therapy when it comes to systemic hormone therapy. I probably still put people on genital urinary syndrome menopause therapy because I usually do find some aspects of either pain at the vulva or, urinary frequency, urgency, the genital urinary syndrome menopause, which is chronic and progressive, that tends to start. A lot of my patients, don't need systemic therapy, but they may in fact and usually do benefit from local estrogen or DHEA therapy. Anyway, that's kind of a summary of all the things, of a lot of the things that were learned. There's more stuff that I can talk about. I just wanted to touch base with you guys again, tell you a little bit about what I've been doing and some of the things that may be coming in the pipeline. And just to remember that, you can really get out there and help yourself improve the quality of your life and, make yourself the best version of yourself. So I just want to say that, there's a lot of things that were discussed at the Menopause conference. There's a lot coming on the pipeline potentially, but, just know what's happening to your body, educate yourself. I'm here to educate so you could advocate, but then you have to be your best advocate. Tune in again next week or the next time I'm able to post Gyno Girl TV. I'm Dr. Smeederman, Gyno Girl in Chicago. I'm here to educate so you can advocate, and I hope that you like and subscribe to my channel. Thanks.